The next item on the agenda, we're very fortunate to have Dr. Fischler here. Jeannie, do you mind if I introduce Dr. Fischler?
Please go ahead.
I'll read a very short bio. Dr. Fischler is a practicing geriatric psychiatrist, the chief of psychiatry and medical director of the mental health and addiction program at the Scarborough Health Network and the Ontario Health East Mental Health and Addiction Physician Lead. He was previously the physician-in-chief and medical director of clinical informatics at Ontario Shore Centre for Mental Health Sciences, where he helped lead initiatives which resulted in the hospital being recognized as the first HIMSS, EMRAM Stage 7 hospital in Canada, and the first Stage 7 mental health hospital in the world. He has served at Scarborough Health Network for the past 14 months, where his priorities include improving the accessibility, integration, and quality of mental health and addiction services through the implementation of standards, central intake, regional partnerships, stepped care, and measurement-based care. Dr. Fischler is also an assistant professor in the Department of Psychiatry at the University of Toronto. Please welcome Dr. Fischler. Welcome, Dr. Fischler.
Thank you so much, Patricia. And it's an honor to be able to present to you today on the mental health impact of the COVID-19 pandemic on healthcare workers. Can everyone hear me okay? You can just give a thumbs up or a nod. Yep, fantastic. I gave a similar presentation at the AGM for Scarborough Health Network, and I was pretty nervous about giving the presentation. A big part of it is that even though I'm a healthcare worker, I do a lot of, I do work in the emergency department. I do call on weekends, overnight. I see lots of patients at SHN. The story for healthcare workers hasn't been the same for everyone. And if anything, this pandemic has really shone a light on the tremendous disparities there are in our healthcare system and in society, and how certain individuals are so much more disadvantaged when it comes to getting equitable care and outcomes in our community. And the mental health impact that this pandemic has had is really no different than the physical impact that this pandemic has had, where those from our most vulnerable communities have been impacted the most. So that will be a part of the lens in which I give this presentation today. So I'm going to give you an overview of the literature, and then I'll talk to you a bit about the scale of the problem. And I'm going to tell you a little bit what we did at Scarborough Health Network to help our workforce and try to get ahead of reducing the mental health impact on our healthcare workers. So next slide. So I'm going to talk a little bit about burnout first. So burnout, it's not a mental illness. It's an occupational syndrome, right? That we're all prone to, no matter what field you work in. But healthcare workers are particularly susceptible to burnout. And there were huge levels of burnout pre-pandemic. So some of the literature would suggest that physicians, nurses, other healthcare workers were experiencing levels of burnout as high as 50%, even before COVID-19 confronted us. And what is burnout? It's really characterized by, three main symptoms. One is this sense of emotional exhaustion, like I can't give anymore, a feeling of being tired all the time, a sense of cynicism, detachment, and irritability. So this sense that, I'm not making a difference, or nothing I do really makes a difference anymore, a sense of annoyance with other people. And then this profound sense of ineffectiveness is that I'm not making a difference anymore. Like whatever I do doesn't have an impact. And those that try to characterize why are healthcare workers so susceptible to burnout would say that it's the end process in which highly motivated and committed individuals lose their spirit. And it really is a crisis in meaning. For many of us that work in healthcare is so much more than a job. It's really about making a larger difference in our community, improving the health and wellness and quality of life of people that may have disadvantages, that may have struggles. And you can imagine that if the meaning of your job is being confronted by the challenges that you're facing in carrying out that work, you're going to be more prone to burnout, that sense of exhaustion, and that, what is the meaning anymore, right? I'm not making a difference. Next slide. And the pandemic has been extraordinarily unique in healthcare, right? So, especially early on in the pandemic, there was this sense of, we've never seen anything like this before, and we didn't know how to safely treat individuals with COVID. If you think about the experience in long-term care, especially, right? Early on, you had PSWs and nurses that were going off work because of exposures, because they were getting sick, because they were frightened. Those that were left in long-term care had an inordinate number of residents to look after. You hear stories about people not getting proper food, not getting proper care. None of that was because healthcare workers didn't want to do the best they could. It was because the demands were inordinate, right? It was because they didn't have enough people to help them out. And when you have that sense that you can no longer make a difference, right? Even though you're running around trying to feed everyone and clean everyone and give everyone a smile, but there's still 10 more people to look after that haven't been changed and fed, that's when you start to feel, what impact am I really having? No matter what my best efforts are, I'm not making a difference. And similarly, you can think in ICU and emergency departments, doctors and nurses or rest therapists trying to figure out how to treat this new illness, COVID. Its scale and duration, especially at the beginning, there was this sense that no one was safe, right? I remember starting, I had a different job actually. As of March 31st, 2020 was my last day at Ontario Shores, which is a psychiatric hospital. And then April 1st was my first day working in acute care after 13 years. And all of a sudden I was going to be going into a hospital that was getting tons of COVID, and my kids were frightened. My wife was frightened. I think someone might have gone on hold or taken themselves
to 11
echo.
on Wednesday, June 30th, 2021.
Can we ask you to put your sound on mute, please? We have some background noise.
So they were scared. I was scared walking into the healthcare setting. And, especially early on with the PPE insecurity, not knowing when a vaccine was going to be ready, and a lot of mixed messaging, right? So hearing different stories about what type of PPE you needed to use to keep safe. Did we need N95s? Were surgical masks enough? Did you need face shields? Did you not? Hearing different hospitals handle it different ways also created a great deal of insecurity. Disruption to the usual way of providing healthcare. I'll talk a bit more about this later in the presentation when I give some personal examples, but overnight, we basically moved from seeing patients in person to seeing people over the phone or through virtual means. And it relied on us taking some risks that we're not used to taking in medicine. I mentioned a little bit about the overload of responsibilities, especially with staff shortages, trying to manage work-life imbalance. So, most other stressful times in healthcare, there's an opportunity to take vacation, get away for a period of time. The last 15 months, really very few people in healthcare have taken a meaningful vacation where they've been able to put work behind them for a period of time. Lack of social support. So, most of us are used to being able to see family and friends in person, go for dinner. All that has been thrown by the wayside over the last 15 months. Lack of control. So those of us that work in healthcare tend to operate from a perspective where we have an internal locus of control. There's been a lot written about those people that feel that they can influence their environment, that they can have impact on the world, and it's their behaviors which make changes in the world. We consider that to be an internal locus of control. It tends to be that that's a more resilient way of operating in the world. Other people, they have an external locus of control, right? It's the sense is that no matter what I do, the world happens to me and I just have to face it. All of a sudden in medicine, there was all of this happening that we really had no control over, right? We were so dependent on government rules, that were changing rapidly, many of which we didn't agree with. weren't happening quickly enough for us, and it was very challenging. Working with colleagues experiencing burnout, and you could imagine, colleagues and patients becoming more irritable as the pandemic wore on and greater fatigue was setting in. Next slide. Not everyone was equally at risk, right? So really interesting study done at the Sinai Health System where they surveyed, I think it was over 1,000 healthcare workers, and Sinai is Mount Sinai, downtown Toronto, and also Bridgepoint, the rehab hospital. And very clearly, they demonstrated that the individuals that were most at risk of burnout and severe distress because of the pandemic were nurses, and they were women. And there's a number of reasons for this. You can imagine many people that were looking after young children at home or elderly parents felt very stretched. They felt very guilty also about not meeting all of the demands at work plus at home. I mean, it was really an impossible task for much of the past 15 months. Again, those with underlying illness were also more at risk. Next slide. So one of the things that's been found to help healthcare workers during times of crises or times of stress is peer support. And Joe Shapiro is an ENT physician, a surgeon that works at Brigham and Women's in Boston, one of the Harvard hospitals, who's developed this peer support model that was initially used for when doctors make medical errors. The whole idea is that, in our careers, we're all going to make errors, unfortunately, unintentionally. But what typically happens after that, traditionally, is that there's no learning from it. Doctors feel such shame is that they can't talk with their colleagues about it and actually learn from the experience. And what she tried to do is create this peer support model where there's proactive checking in with doctors after medical errors to try to reduce the shame, try to help people explore their emotions, and to connect them to resources. And during the pandemic, they totally ramped it up. So it was no longer about just supporting people who made medical errors. It was about supporting everyone, doctors, nurses, other healthcare workers, and they took a very proactive approach. You didn't have to reach out for peer support. The peer supporters were going to reach out to everyone else. And I listened to this podcast that she did with the Canadian Medical Association. One of the most interesting things that she spoke about was the emotions experienced by healthcare workers were so different than what they usually saw in peer support. So obviously, everyone's emotions are different. Everyone has experienced this pandemic in a different way. But some of the common emotions that she saw was grief, a lot of grief in terms of seeing patients that traditionally wouldn't have been dying in ICUs and medicine wards dying, a huge sense of guilt, of not doing more for patients, of not doing more for their colleagues, right? There's a real sense of team and camaraderie in healthcare, and especially early on when people had to go off because of exposures and knowing that team members were kind of left behind holding the fort, it compounded guilt. A sense of anxiety, a huge amount of anxiety about bringing it home to their families, about what the future is going to hold. And then one of the most common emotions, which I've seen also, is this tremendous sense of anger. A lot of it is anger at society and anger at government, matched with gratefulness, right? Joe talked about how she survived COVID and her husband did too, and how they were so grateful for that without getting, horribly sick. She got pretty sick, where she thought she almost would need to be hospitalized. But she also spoke about the anger that healthcare workers are experiencing in the States. And I see it in Canada too. I mean, there's a social contract, I think, that people who work in healthcare have with governments and society, is that, in general, society will, take some steps to try to make, the work that people in healthcare do somewhat easier, right? And what the pandemic did was shine such a light on the discrepancies between rich and poor, between first generation Canadians and those that have been here longer, for the discrepancy between Indigenous people, the Black community, persons of color, and white people, and how as a whole society didn't feel like society was taking proactive, strong steps to address the differential impact that the pandemic was having on our most vulnerable communities, those that still have to go to work every day at an Amazon warehouse or at the grocery store, or as a caregiver for other people, bringing it home to their families and multi-generational households, having the biggest impact financially, while those that are the wealthiest in society continue to get richer, and there wasn't any, paid sick leave for people to take time off if they, had an exposure or needed to get tested. Next slide. And I think a big part of this story about the mental health impact of COVID on healthcare workers is the social and structural disparities that COVID has had on vulnerable communities. Again, if you think of burnout as an occupational syndrome that attacks a sense of meaning, for so much of our work is about improving the lives of those that are the most vulnerable, those that are the most sick, those that need it. And this was a study done in Chicago as part of their crisis response table, and they sent out surveys, hundreds of surveys, and they found that the Black and Latinx populations during COVID reported significantly more difficulties accessing basic things like food, supply, healthcare during COVID pandemic compared to other members of the population. And this wasn't part of the study, but it's well known Chicago is no different than really anywhere else in North America, where individuals that come from Black or racialized populations died at much higher rates compared to their proportional representation in that population. And even healthcare access disparities. I mean, we know in Scarborough, individuals who live in Scarborough access healthcare at a much lower rate than would be expected based on the social determinants of health and the burden of illness in the population, right? And you'd think in a publicly funded healthcare system, there should be no discrepancies between healthcare access. The Chicago study, where it makes sense, it's a private healthcare system in the US, they showed there were significant discrepancies to accessing healthcare during COVID-19 there, but we're definitely seeing the same thing here. Next slide. And it's a similar story regarding the disparities and impact of the pandemic on sexual and gender minorities, right? We knew that there were already disparities around social support and mental health of sexual and gender minorities pre-pandemic, but the intersection of the pandemic-related trauma with existing mental health burden, minority stress, lifetime discrimination, the experiences of family rejection, substance use challenges, and dimensions of social inequality just ballooned the impact. And one of the US national surveys noted substantial changes across several measures of well-being for gay men, bisexual men and women, and other sexual minority women. And these changes were much greater when compared to same gender heterosexual adults. And sexual and gender minority young adults experience higher levels of PTSD, depression, and COVID-19 related worry, even after controlling for some of the potential confounders that we usually associate with why people from sexual and gender minorities may experience higher mental health burdens, right? So things like family support, lifetime discrimination, and pre-existing mental health conditions. So we often think that is the driver for why individuals that come from sexual and gender minorities have more mental illness or more substance use challenges. But this study actually showed that the impact of the COVID-19 pandemic was greater above and beyond some of those potential confounders. Next slide. And there's been some hypotheses in the literature about why this may be the case. So the social isolation mandate may re-traumatize some sexual and gender minority young adults who commonly have histories of victimization and rejection. Many young people return to their parents' home, and it had a major impact on privacy, access to their usual supports, and the level at which they can be out and a loss of connection to and participation in the LGBTQS2 positive communities. Next slide. And one of the things that, I think society tried to do early on, and it was supported by government, was kind of brandishing, the PSWs, the nurses, and other healthcare workers as the healthcare hero, right? With the pots and pans being rang once a week, to celebrate the sacrifices that people are making. And certainly, I think early on, it emboldened healthcare workers to some degree. But there has been some harms associated with the two that I think need to be discussed. So next slide. So what is this idea about the healthcare hero, right? So when you think about a hero, you usually think about people in war terms, right? The person that, sacrifices their personal safety in defense of their country or certain values. Or you think about the superhero, someone that really has no personal needs aside from trying to, save other people. But, again, most of us that go into healthcare, we're regular people that want to make a difference in our communities, want to make a difference in other people's lives, but we don't go into it with kind of a war mentality, right? We tend to be more emotional. We tend to see ourselves as being more vulnerable. So the idea around this healthcare hero term was it discouraging, healthcare workers from actually allowing themselves to be vulnerable and seeking help when they were suffering and processing their feelings. And, one nurse, Shan Mohammed at University of Toronto, did a really interesting post-structural discourse analysis, looking at all the, articles about healthcare hero that were quoted in literature, and some of the themes that came up is that the term may be used to actually suppress some healthcare workers' working conditions, right? And being able to advocate for better working conditions. I mean, I don't think it's going to be a surprise to, anyone that's part of this meeting that, most of the nurses and PSWs and point of care healthcare workers that support our institutions come from visible minority groups or women and are systematically disadvantaged. And, was this healthcare hero term a way of kind of shutting off the conversation about what else is needed to actually embolden these individuals that are performing a huge service to society, but to great personal risk to themselves and their families? And just to highlight too, the issue about Bill 124 in Ontario, it just seems like such a discrepancy to hail the healthcare hero, but try to have legislation that keeps the pace of wage increases at lower than a rate of inflation. At the same time, that corporate Canada has made huge amounts of money in many areas during this pandemic. Next slide. And so the scale of the problem. So one UK study that was done by the British Medical Association, again, in the first wave of the pandemic, which probably from burnout, burden of mental illness was the least affected, was the first wave, because it was still early on. And I think people were hoping that there was going to be an earlier end than there has been. It showed 45% of UK physicians were suffering from depression, anxiety, or burnout related to or made worse by the pandemic. And the Sinai Health System study, which I referenced before, it showed a significant increase in severe emotional exhaustion, which is a great proxy for burnout. And it showed that it actually rose by about 20% between the fall of 2020, right, which was after the first wave when things were a bit more settled, and winter 2021, which is when we were going from the second to the third wave. And in particular, nurses saw the largest increase in severe emotional exhaustion, from 54 to 63%. And during that same period, the degree of psychological distress that likely indicated a major mental illness rose by 20% in study participants. Next slide. And we tried to do, so I'll talk a little bit about the Scarborough Health Network strategy, but we sent surveys, voluntary surveys every 2 weeks to all the staff working at Scarborough Health Network and asked them to complete some validated scales, looking at levels of anxiety, looking at levels of depression. You know, anything between 5 and 10 is considered to be mild illness. Anything above 10, you're already looking at kind of mild to moderate. And you can see it's a biased sample, right? Scarborough Health Network has thousands of employees and physicians, and we're only seeing, you know, 100 or a couple hundred completions every 2 weeks. But you can see a trend to where the scale of the problem is increasing between after the first wave and at the third wave. Next slide. So what helps to support healthcare workers? So one is support, and support can come in a number of different ways. Like there is evidence that peer support programs do help healthcare workers to cope under stressful situations. You know, I think organizational and societal support also makes a really big difference as well. Having structures in place to ensure that when healthcare workers are feeling burnt out, need time off, need treatment for mental illness, that it's easily accessible. That's actually one of the things that I think government did reasonably well at the beginning of the pandemic, is that at the very first stages, they set up with some of the specialty mental health hospitals in the province, low barrier access to mental health care. So like any person working in healthcare could go on the CAMH or Ontario Shores website and self-refer to see a psychiatrist or a therapist quickly. The next is appreciation, and that goes beyond, I think, banging pots or saying that people are heroes, but really tangible appreciation, personal appreciation. You know, it could be gifts, it could be handwritten notes, but something very practical that helps to resonate with the meaning that the career has to the individual worker, right? If we look at burnout as a crisis of meaning, where you feel like you're not making a difference, the appreciation needs to tap into, wow, so-and-so really actually does care about the difference I'm making, and they can actually see it, they're observing it. It goes a long way to helping to boost individual resilience. Creating psychologically safe workplaces. I'll talk a bit more about this in a bit as well. You know, but part of creating psychologically safe workplaces is allowing space for people to be vulnerable. It's allowing space for people to have differences of opinion, where people don't feel silenced, and that you can talk about these things without worrying about conflict developing. And you know, what's not psychologically safe is if there's a sense that everyone has to pretend that everything's okay all the time. And promoting resilience. And resilience is a complicated phenomena that I'll talk about, but that also helps. So next slide. So the approach we took at Scarborough Health Network was multi-pronged, and I was in a bit of a kind of an unusual situation. As I said, I came at the, April 1st, Scarborough Health Network, kind of terrified. And the first day I get a call from my new physician-in-chief and saying, Ilan, we're worried about the impact of the mental health on the pandemic. Can you help us create a strategy to help our healthcare workers? It's luckily I reached out to a lot of colleagues. One of the doctors in our program is actually an occupational psychiatrist, probably one of the only ones in the province. And, with a lot of help, we came up with a vision and a strategy. And the vision was to create a comprehensive and effective program to optimize Scarborough Mental Health Network staff mental health during the COVID-19 pandemic, using the principles of population health, right? So it wasn't just going to be a reach-in model. It wasn't going to be, okay, here's the resources, connect if you have a problem. It is that we were going to try to keep our eye on where the hotspots were and do more reach out. So the three-pronged strategy included consistent, reliable, and positive communication, so that everyone knew what was going on at every point in time and what the hospital policies are, what we were promoting. The second one was promoting staff wellness and resilience. And that was done through a number of strategies. We have this amazing wellness coordinator, Philippa Dawood, who some of you may have seen on Global News, who was rounding on all the different units. She was leading Zumba classes and mindfulness exercises. And she went around with our spiritual care team and our mental health care team, and she would lead discussions. And if people wanted to talk with one of our mental health staff to the side, they had the opportunity to do that. She would advertise the resources that we had, and encourage people to also use the self-rating scales that we had as part of our data collection strategy. So that was the third part, which was screening, identification of hotspots, and connecting people to resources and treatment. So every 2 weeks, everyone got these validated scales mailed to them. They were completely anonymous. And the population health strategy part was that based on how you scored on that scale, you would get automatic recommendations. So lower intensity resources, non-medical in nature, if you had very mild symptoms, all the way up to, connecting with a psychiatrist or therapist within the next 24 hours. And at the back end of this process is we could look at the data and see which parts of the hospital were experiencing more depression and anxiety, right? Like, so ICU, we saw it more, and Emerge, we saw it more. Next slide. This is just an example of bookmarks that Philippa and her team would take to the units. We had created this website, mental health at shn.ca, that allowed any of our staff to be connected to a psychiatrist or therapist within 48 hours by emailing us. No referral needed. Next slide. And then, through this data strategy, we were able to identify some of the hotspots. And what we ended up doing was that my colleague, Aryan Bazadi, he's also a psychiatrist, and myself would go and do a presentation to small groups. We did it to small groups of physicians. We did it to small groups of leaders. We did it to some groups that were outside of SHN as well. And the whole idea was talk a bit about burnout, help to create a psychologically self workspace. So we made ourselves vulnerable and talked about our own experiences, and try to create a space where people could step out of the everyday action mode, right? Like, we're so focused on action this last year. What are we going to do next? What do we have to do to prevent this rising tide coming into our emergency department, not having enough beds? It was supposed to allow people to kind of step outside that and say, what have I actually been feeling and experiencing these last months? And, what do I need to help myself? So, Aryan would speak very openly about his experience, which happened during the pandemic, the first time in his career where he had a patient die of suicide, which is an unfortunate tragedy. It's something, unfortunately, that most of us in my profession have to deal with at some point. But the horrible sense of guilt he experienced and shame, especially because it was early on in the pandemic and he didn't see the patient in person. Everything was done virtually. So he started to second guess whether he did the right thing. And he talked about, how getting some additional help made a difference for him, and speaking to colleagues made a difference for him. And then I spoke about my own experience with clinical depression and generalized anxiety. It's one of the things that I was committed to when I joined SHN, is that I was going to be open about the fact that, I've had clinical depression and generalized anxiety for most of my adult life, and I've received treatment on and off over the years, both psychotherapy and medications. And medications I'll take for the rest of my life. But at the beginning of the pandemic, starting this new job, I felt the depression and anxiety really coming back. Difficulty sleeping, losing my appetite, feeling really overwhelmed and anxious, trying to wonder, do I really know what I'm doing? Am I an imposter? And what helped me was reaching out to a psychiatrist that I hadn't seen in a couple of years. And it made a world of difference. And what we were really hoping by telling these stories about ourselves is that if people are suffering, or they notice that, they're not feeling the way that they usually do, is that, again, not everything has to be medicalized. Not everything means you need to go see a psychiatrist, but there's no shame in doing it, right? It's it's enormously helpful. Next slide. So I mentioned these targeted small group sessions. And then the other piece that we added in there was very practical resilience advice, which I think I'm talking about on the next slide, if you can go to the next slide. Yeah, so resilience. And, you know, a resilience is a sense of control over your emotional reactions, right? A sense of control over the outside and the inside, and a sense of ongoing, continuous, and contagious meaningfulness. And you regain the resilience by regaining that sense of, this is the way I like to do it in the new environment, right? It's reconnecting with meaning. It's reconnecting with why you're doing what you're doing. I always had a bit of a problem with the term resilience because I always thought it had this very negative connotation, right? Is that, well, if you're depressed or you're anxious, it means that you're not resilient. And it's actually completely not true. That's not what resilience means at all. And it's not just an individual responsibility to sustain or create resilience, right? It's an organizational responsibility. It's societal responsibility. Even though there are individual things that we can do to shore up our own resilience, it can't just fall on the burden of the individual. So, you know, one of the things that I like to say, and that I've heard others say, is that as healthcare workers, we've already demonstrated that we're resilient, right? You know, one of the people that came back to me after we did one of these talks was a leader who said, you know, she had a really difficult day, and I think she was crying to one of her other leaders, and what the leader said, you know, you really need to be more resilient, and that felt like a bit of an attack to her, right? But it really isn't about that. She is resilient, right? You wouldn't be in a healthcare leadership position if you weren't a resilient person. You wouldn't have gone through medical school if you weren't a resilient person. Like, you faced a lot of stress in your life before, but in the face of inordinate demands, without the appropriate societal and organizational supports, we're all susceptible to burnout, depression, anxiety, PTSD, and substance use problems. So it isn't a something to blame yourself for, right? If you're feeling these things, and it isn't something just individuals need to be responsible for themselves. We need to look at it as a society, how we can help to boost our healthcare workers' resilience. Next slide. And then we would talk about the 5 C's of individual resilience. And I got these from Dr. Mamta Gautam. She's a psychiatrist in Ottawa, and her whole career now is focused on treating doctors, treating burnout, treating depression and anxiety. And she does a lot of talks for like the Ontario Medical Association and other physician groups. And she says, focus on these 5 C's, and this will really help you. And I've tried to practice it during the pandemic. So one is focus on what you control. Don't focus on what you can't control. So one of the biggest stresses I had during the pandemic, and that I still experience, is that there are people in my family, you know, extended family that I care a great deal about and I love. They don't follow the public health guidelines in the way I want them to. It drives me crazy, right? It does. If I let it drive me crazy, it drives me crazy, right? And now that, you know, most of the adults in my family are vaccinated, we have these discussions about, you know, when can we start seeing each other again? You know, when can we be inside of each other's houses? But the one thing I always have to remind myself, focus on what I can control. I can control my own responses. I can control my own attitudes. I cannot control my, you know, parents' behavior, my siblings' behavior, my aunts and uncles' behaviors, right? Those are not in my control, right? And I can advocate, but the more that I can compartmentalize that internally, the more powerful I know I can feel, the more settled I can feel. Reconnecting with commitment. And it's part of why I love doing these talks, even though I get nervous for them, is that it really gets to what's meaningful to me about being a psychiatrist, right? Is that, you know, I know that, you know, without some of the resources I've had, I wouldn't be in as good a state as I am today, right? Like, my depression and anxiety would be much worse. And, you know, I have a lot of privilege in my life that a lot of people don't have. And that's one of my commitments to Scarborough, is that I really do want us to be able to produce better health outcomes for our most vulnerable. And that is part of reducing the inequities in society, right? So being able to speak to groups about the impact that this has had on healthcare workers, and especially groups that serve those that are most vulnerable, feels particularly meaningful to me. It helps to re-energize me in the face of busy work or busy days. So that's another C. Caring connections, and that means reminding to connect with your friends, right? Even though we can't do it the way we've always done it, it means forcing yourself to set up Zoom calls with colleagues that, you know, work at different places and check in and see how they're doing. Calming. So calming often refers to things like doing mindfulness or meditation or yoga, all things I'm not great at doing. So I say the two most calming things I discovered during the pandemic were doing Lego. I started buying these very expensive Lego sets that I find very mindful because it gets me out of my own head, and doing this thing called diamond dots, where you're basically drawing these pictures with little diamonds. It takes hours. So again, the idea is getting out of the everyday worry and focusing on the moment. That is what being mindful is about. Here, now, in the moment. And then the last C is caring for yourself, right? Is trying to put aside that shame and guilt and allow yourself to care for yourself. Next slide. And then we share the resources, right? And I mentioned our internal resource where you can be connected to a psychiatrist or therapist at SHN. You know, there was this ECHO program that CAMH did every Friday from 2 to 3. All healthcare workers were invited, where healthcare workers could talk about the experience during the pandemic, and it was facilitated. You know, Ontario Shores and CAMH had these programs for health professionals. So again, normalizing and trying to encourage people to seek help. Next slide. And over time, we did see more referrals. You know, in May, I had spoken to one of the VPs at CAMH. They said they were barely getting any referrals at the beginning of the pandemic, up until January. But as soon as the second wave hit, they got a magnitude 3 times the referrals that they were getting earlier on, and they were needing help from other hospitals to support all the healthcare workers that were reaching out. And the need is going to likely increase post-pandemic, right? We know from all the trauma literature, people aren't the most distressed in the middle of the trauma. It's after the trauma that people are most distressed, right? We don't know what 15 plus months of trauma is going to look like to healthcare workers, you know, 6 months to a year down the line, but we can anticipate that more is going to be needed to be done to support them and ensure that they're healthy. Next slide. So, you know, the COVID-19 has had a profound impact on the mental health of healthcare workers. And, you know, it hasn't been equal, right? There's been real disparities along the same disparities that there have been in general society. You know, society, government, and organizations really do need to think more about how they're going to address societal inequity and support healthcare workers post-pandemic. You know, and appreciation, peer support, and formal mental health supports and programs with low barrier access are likely to be part of the solution. So thank you so much for your time today, and I'm happy to take any questions if there's time.
Thank you, Dr. Fischler. And the floor is open if anyone had questions or comments. First, I just wanted to thank you for sharing your expertise on the topic. I think it's very timely, of course. Everyone's having these conversations, I think, in their workplaces, among their friends, how everyone's doing. But what's also, I think, important is to hear your own personal story, because I think that helps everyone else open up to talk about what they've been experiencing as well. So thank you for that candor. And overall, I think it was a lot of helpful information to help us manage and discuss the challenges we may be facing as individuals as well. So any other comments for Dr. Fischler? Thank you so much. Great, that was fantastic. And thank you so much for your time at the AGM this year. We much appreciate your presentation.
My pleasure, and enjoy the rest of your AGM.